So, good afternoon, everyone, and welcome to this webinar. And we're really pleased and honored to have Dr. Parminder Suchdev as one of our Center for Global Health directors, providing his view in the following seminar. And this is a few housekeeping rules, one of which is that I know many of you are attending, and please use the Q&A button on the bottom of your screen to post your questions, and I will be monitoring that. And I would make sure that as many of the questions get answered and be made available. So Parmi, you would then also look at the Q&A section to see if there are questions that you could take on and answer, and of those that you don't, I will collect those and write them down and then repose them back to you as a group question if we don't get to all of them. I hope that makes sense. And with really great pleasure, may I just introduce Dr. Parminder Suchdev, and he would begin the session with his seminar. Please go ahead.
Yeah, thanks, Dr. Chu. I just want to make sure, are you guys seeing my big screen? Is that looking okay on the webinar?
So we're seeing your slide editing screen. We're not seeing full screen slides.
Yeah, sorry. Thanks for that clarification. With multiple monitors, it always seems to. Okay, that better?
Yes, we now see your full screen slides. Thank you.
Yeah, thanks for that. Also, it's a pleasure to be with all of you guys. Greetings from Guatemala. My talk is titled A Personal Journey to Combat Malnutrition and Advocate for Global Health Equity, a proposed vision for the Center for Global Health. So I live and work in Guatemala City, where I moved with my family last year on our first overseas assignment with the CDC. Both the CDC and the U.S. Embassy Guatemala were situated here on the ancestral land of the Mayan people, which is a diverse ethno-linguistic group in Guatemala and much of southern Mexico and Central America. And as a result of the arrival of Europeans, there's been erosion of the indigenous people's sovereignty that's impacted not only their land, but their culture, worldviews, and harmonious nature, relationship with nature. So the overview of my presentation is to both give you my personal journey in global health, as well as a proposed vision for the Center for Global Health. And I want to acknowledge that I'm an outsider. And so these are just some ideas, and clearly to implement a vision for the center, it's going to require input from faculty, students, staff, and really all of you before launching. But I'll discuss my experiences and proposed ideas in these 4 categories: and clinical care and community outreach, interdisciplinary research, global health education, and all those grounded in equity and social justice. So with that, just as a personal introduction, so I was born in the U.S., first-generation immigrant. No physicians in my family. I'm the first one to pursue medical training, and this was me as a second-year medical student in Nicaragua, doing what I would call now medical tourism. But at that time, I thought I was doing something useful. In my broken Spanish, talking to this mom about the importance of eating a healthy diet to prevent anemia in her child. And I bring this up because I think many of us start in global health in different ways. We have different ambitions, different aspirations. It can be the desire to travel, the desire to do good, the desire to change the world. And then we dedicate our careers to this, and many challenges take place during that journey. So one of the other early experiences for me, also in medical school, was an outbreak that took place. So I was doing my MPH training at the same time, and some of my younger classmates had returned from Jamaica from spring break and came back with severe headaches, and student health was, okay, just take some Motrin or Tylenol, you'll be fine. And then one of my classmates, she had a seizure, was hospitalized, and they found out she had eosinophilic meningitis, and it was found to be Andrew-Strongylus cantonesis, which hadn't been really seen in the Western Hemisphere. And so, as a student, I was brought in. The CDC was brought in and was brought into this outbreak investigation, and that was the moment I was convinced. I really wanted to work in public health and work at the CDC. So following my training in pediatrics and at the University of Washington, I came to Atlanta in 2005 to participate in EIS. And really, to me, my career has been this kind of mix of clinical medicine as well as public health. And to me, global health is the glue that bridges these two worlds. And I really align myself with these 3 bullet points, these principles of global health that focus on health equity, interdisciplinary collaboration, irrespective of one's geographical boundaries. So global health is not just working outside of our countries, but also working within our communities as well. And my career has really been this constant kind of balancing or juggling act between the worlds of clinical medicine and public health. And I feel over time at Emory, I've created like essentially 5 jobs for myself. And Emory happens to be a place where all these places are on the same road, Clifton Road. So where I spent time as a practicing pediatrician into school medicine, training residents and fellows, practicing medicine, but also in the School of Public Health, teaching courses in the School of Public Health, spending time at CDC and doing global health administration. With our Global Health Institute, and as part of this, I was feeling pretty like burnt out. I could say with balancing all this, and felt that the missing piece in my global health journey was living overseas. All my global health work had been done from Atlanta, going overseas, and so I took the opportunity a couple of years ago to join the CDC here in Central America as part of the Division of Global Health Protection as the head epidemiologist. And it's been almost 2 years, and our group here focuses on all the countries in Central America and the Dominican Republic, and work in many broad areas of global health and public health, in particular surveillance, migration, emergency management and response. And one of the core values that I've really been kind of pushing for, and what I feel like I hope is the lasting impact in my short time here is the issue of health equity, because to me that's been quote the elephant in the room in terms of what I've experienced during my time in Central America. And it's been a great time, and I think it's exactly what I needed in terms of what a sabbatical could look like, especially for the family. This is my family, my partner, and our 2 kids. And they don't want to leave. they're like, sign us up. We're here for good. I miss academics. I miss working in global health and building programs. And so I'm ready to come back. We also have adopted a puppy, and then personally, like I've really gotten the chance to, or professionally, I've gotten a chance to work in some new areas. I come from chronic disease and nutrition, and have had to work on things including the COVID pandemic. We had several monkeypox cases, and as a CDC way, you become an expert very quickly, and now are leading webinars on these topics, and in Spanish, and then we're working a lot on diversity, equity, and inclusion with both our embassy community, but also more broadly within Guatemala has been another one of my areas of focus. So then let me talk a little bit more then about kind of my journey amongst these 4 areas, and then with each of these we'll give some ideas on opportunities that I think could be grown at the Center for Global Health. So we'll start with clinical care and community outreach. And so, as I mentioned, I'm a pediatric hospitalist with expertise in clinical nutrition. So I have practiced at Children's Healthcare Atlanta, which is a large pediatric system, very similar to Children's in Colorado. More recently, I've joined our county hospital, Hugh Spalding, which I really enjoy. It's taking care of it's more community-based medicine, families who often don't have resources, and I'm really enjoying my time there. I'm also been really involved with the American Academy of Pediatrics, the former chair of the section on global health, and I'm currently sitting on the committee on nutrition. And I've done a lot with the AP in terms of advocacy, both for global health as well as global nutrition. And one of my other areas of clinical interest is immigrant and refugee health, which I think is a potential opportunity in Colorado. Georgia is the sixth largest refugee resettlement state. And a few years ago, we started a refugee and immigrant health alliance across the School of Medicine, School of Public Health, to try to create a medical home for refugees, because in Georgia, when refugees arrive, after they get their initial medical screening exam, they're kind of on their own to find, a primary care provider, and then often lost. And so that's one of the things REWA has tried to do, is to establish that care for new arrivals. So on that note, some opportunities for community engagement at CGH. I think could be immigrant and refugee health. There's a lot already happening. I've been involved with Janine Young before. I know she moved on, but there are many others who are working in this area. The Colorado Refugee Services Program within the Department of Health, and I think this could be an area of global health, but local health. And I think that can be very, very tied together. Potential opportunities for international adoption clinics. These can also be very tied with those who have infectious disease expertise, international work, but then applying that locally. And I know Children's has been involved in improving access to care for underserved communities through the Children's Colorado Health Pavilion. So these could be opportunities, I think, for the center to engage with as well. So next, I'll briefly talk about research and interdisciplinary research. And these are the causes of under 5 mortality estimates. And this was the slide when I first joined CDC, because when you do EIS, it's like a match in residency. You make a rank list, and you can work in malaria and cancer and all different things. I ended up in nutrition, and I basically picked nutrition because of the slide. And I was surprised, because as a pediatrics resident, I learned a lot about the outer sides of this graph: diarrhea, malaria, HIV/AIDS, infections that cause child mortality. But I was shocked to learn that about half of child death is associated with nutrition, and that's really been the driving force to really make me want to work in nutrition. And nutrition not only affects mortality, but it also affects morbidity. And really, if you had to pick one organ that nutrition can have an important impact on, it's the brain in terms of child neurodevelopment. And I've also really been fascinated with this kind of bidirectional relationship between nutrition and infection, and that poor nutrition can affect your immune response, your ability to recover from infections, but infections themselves can also make you malnourished. And to really untangle this relationship is critical if we want to collectively improve child neurodevelopment. And if I have to summarize one quote that defines my research interests, it's this quote from Lord Kelvin: "If you can't measure it, you can't improve it." And so I really think assessment, really understanding how to assess and measure nutrition is critical. And there are many gaps in this area. So just to briefly mention, one side is anthropometry. So this is the side of malnutrition, protein energy malnutrition, and the flip side is micronutrient malnutrition. But with protein energy malnutrition, it's sometimes assumed by non-nutritionists that this is super easy. All of us as children were followed on a growth chart by our pediatrician, and if you have children, they get their measurements taken. But there are a lot of gaps in how these measurements are taken, and if they're taken well, and how they're interpreted. So this is just one example. This is looking at general pediatric patients admitted to our hospital over the course of 1 year, and just looked at their heights. And so 20% of children on the general pediatrics wards at Children's Health Carolina didn't even have a height measured. And those that did, this is the distribution in red. And so you can see a few things here. The most notably is the median is pretty close to normal, but you have these really big tails. So the standard deviation is wide, and this is basically an issue of measurement error. They're just not the measurements aren't taken well. So we did a quality improvement project and bought height boards for the wards and tried to improve these measurements. And essentially after a year, there was no improvement. They actually got worse. So it was a failure. But what this led us to do then is to figure out how can we make these measurements easier for busy nurses and providers. And so worked with a company to develop this body imaging tool. It's basically a device that you can put on any tablet, and it takes a 3D image through some still photographs, which is basically what gamers do, I guess, to create avatars of themselves. But then with this 3D image, you can now measure head circumference, you can measure length, you can estimate body volume. And we found this works pretty well, at least in Atlanta. We've tried this in a few resource limited settings and not quite ready for prime time there due to internet availability, poor lighting. But I think this could definitely be the future. And so that's just one of the themes, I think, is applying innovations and technologies to global health, and then the idea of that these technologies can also improve the way we do medicine here in the U.S. So it's not just something that's used in rural Africa. This is something that can improve the care, of someone in ICU in Denver. And on the flip side, on micronutrient status, this can also be challenging because to measure micronutrient status, it requires a lab, it requires blood. And so there's also opportunities to measure micronutrients non-invasively and with less resources. So this is an app that was created by a Georgia Tech student. Emory does not have a school of engineering, so it's we work with Georgia Tech, and this basically takes a photo of your nail bed, and it's able to estimate your hemoglobin. And this is just a summary of the research group that I've been involved with since 2012. And essentially, it's you're looking at big data from nutrition surveys and compiling them and asking secondary questions related to nutrition and infection. And it's been a big success. We've been very active in terms of publications and have led to a couple of different WHO guidelines on how to measure assessment, and have had continuous funding now for over 10 years, primarily from the Bill and Melinda Gates Foundation, but from some others, as you can see in the slide. And just to give you a snapshot of one of the things that's interesting to me and what we look at is this idea of the acute phase response. This is an innate response that we all have. You can get it from infection, but also from stress. And you produce inflammatory cytokines, and then the liver produces acute phase proteins. Clinicians in a room will be very familiar with CRPs. There are other types of acute phase proteins like alpha-1 acid glycoprotein, which is a more chronic measure of inflammation. But the issue, some of our biomarkers of nutrition are themselves acute phase proteins and can artificially be elevated like ferritin or artificially depressed like retinol binding protein. So just to give you an example, this is the prevalence of vitamin A deficiency in 8 countries in blue. And according to WHO, 6 out of these 8 countries would be considered to have severe vitamin A deficiency. However, after you apply some statistical corrections accounting for inflammation, you find out that the prevalence is actually much lower. So we're actually overestimating vitamin A deficiency globally. And so these are the things that WHO is now doing so that when you measure these biomarkers prospectively, you can apply these statistical adjustments to get a better estimate of what's really happening. Another area I'm interested in is just this role of nutrition and mortality and some of the gaps in terms of how do you best measure it and how do you account for malnutrition in all its forms, both the protein energy malnutrition as well as micronutrient deficiencies. And a big study we've been involved with at Emory is called CHAMPS. This is now in its 12th year. It's the largest grant ever received by the university and the largest grant issued by the Bill and Melinda Gates Foundation. Now over $300 million, and really the idea is to basically remake that pie chart I showed you on the causes of child mortality and to more definitively determine what is really causing death, so that therefore we can then prevent them. And so we set up surveillance sites in several countries in sub-Saharan Africa and South Asia. And through my connections in the foundation and nutrition, have created a component to the study assessing the role of micronutrients in CHAMPS. And so essentially we're using the same surveillance network and measuring micronutrients both in children who have died using tissue sampling like liver, blood, other tissue samples to measure micronutrients, as well as in pregnant women. And we're collaborating with the University of Colorado with Nancy Krebs and her group to do the liver zinc and liver iron measurements. And so I'll actually be heading to Kenya this Friday to launch the pregnancy surveillance part of that study. So in terms of potential areas of growth, I mentioned Nancy Krebs. She's been a strong partner, colleague, mentor for much time. And I think one idea would be to establish a center or an area focused on climate change, nutrition, and health. I think a lot of these things are already happening at University of Colorado, but really elevating it to the next level. And one of the things that really excites me about Colorado is just the expertise and laboratories. And there's a big gap in global health on laboratory assessment, on biomarkers, and could that be elevated where Colorado would be like the one-stop shop to provide technical assistance on how to do assessments, not just in nutrition but in other areas of global health, infectious diseases, et cetera, with the goal of building these capacities in low and middle income countries. I think some other areas would be additional funding partnerships through connections with the Bill and Melinda Gates Foundation, through Fogarty, USAID, other big funding opportunities as well. And I think an area of research that's exciting to me is research that really goes across disciplines. And so a couple of programs we did at Emory that I think could be replicated. One really issuing grants from the Center for Global Health to faculty, but these grants have to require 2 or more schools. So it can't just be pediatrics and medicine or emergency medicine and anesthesia. It requires faculty to have co-PIs across schools, and it could be schools in health sciences, but even outside the health sciences. And this has really led to some innovative proposals that have then led to large fundings. The return on investments we've tracked are about 17 to 1 on these seed grants. And then another program that I think could be replicated, something called Faculty Fellows. So can we bring faculty across different schools? These faculty could be nominated by their deans or their department chairs, and they would essentially be the think tanks for global health under the Center for Global Health, so that when there's a need that comes up, there's a grant opportunity, an RFA, you have this group ready to go and can mobilize and go for these research opportunities. So next, teaching and mentoring. So just a snapshot, I teach in the School of Medicine, but also in our graduate school in the Nutrition and Health Sciences program. We have a PhD program, and these are just some of the students I've mentored. I'm currently on the primary mentor for a PhD student here who's going to be defending in a couple of weeks. So that's always exciting. It's one of the things I enjoy most is working with trainees. And this was a piece we wrote 10 years ago with a couple of my mentors on what is the role of global health to academic health centers. Why should deans and chancellors invest in global health? And the argument we made is global health actually strengthens the mission of academic health centers, whether that's patient care, education and training, or research. Global health can enhance these, and that's the reason why these should happen. And I think education is a big part of it, because trainees are really the ones that are demanding global health. As I'm sure as in Colorado, trainees are always knocking on our doors, looking for opportunities to have these experiences. So just some examples. In 2011, as a junior faculty member, started a global health track in pediatrics, and as part of that development, it's like, why recreate the wheel? Let's bring together others who are already doing this. And at that time, there were a few global health tracks, and we wrote a paper on a model curriculum. And this curriculum now is being used by over 100 residency programs in terms of how do you do global health in pediatrics. And then we recently in pediatrics launched an office, the Global Health Office of Pediatrics, because over the 10 plus years of doing education, that's gone well, but how can we hit the other missions of global health? So now this office it's like a mini division or section that now can tackle the research piece as well. And so it's so that there's one place that faculty can go to. And then one of the other gaps that I saw a lot at Emory was that the School of Medicine was not very organized in its global health, and it took quite some time, but over years, and using this visual as a convincing standpoint to the dean on why should Emory have a global health program, and somehow there's a cause effect. I don't know if that's really true, but if they would now be in the top 10 schools, because all the top 10 schools actually have some global health pathways. We were able to launch a global health office, and this I was able to put together right before I left on sabbatical. It's called the School of Medicine Global Health and Equity Office, and it's an administrative home for faculty, staff, and trainees working in all aspects of global health. So what are some potential areas of growth then in terms of education and faculty development at CGH? I think there's several global health fellowships. I got to meet with Corey Bills this morning, learned a lot about their fantastic program in emergency medicine. I know Dan Olson and Lisa Humphrey are leading work in pediatrics. Could these be somehow integrated so that they're common pathways? How can we sustain funding for these, so rather than them happening at department level? Can we get NIH funding like a T32? I think there's opportunities to replicate what's amazing happening in Guatemala, replicate this education and research platform to new sites in Africa and South Asia. And I think there could be an opportunity to do some visibility. One of the things we did at Emory was start a global health forum series and on timely topics in global health. And these were quarterly, not very often, but but it would bring together people from across the university, and then the Global Health Institute would be front and center in terms of putting this together. So this is an example on racism and global health. We did a whole series on decolonizing global health. So I think these would be other examples that could be replicated. So finally, health equity, and some of my views on health equity. So this is a graph showing the share of people vaccinated against COVID-19, and this is one of the figures that troubled me when I arrived to Guatemala, because Guatemala is at the bottom. And not even close to some of the other countries, and even as of today, it's still about 1 out of 2 people have been vaccinated with COVID-19, and the question is why? Is it a lack of access? The fact that Guatemala has a lot of rural populations. What are some of the reasons? And what I've come to find is it's multiple reasons, but kind of the biggest gap is really the division amongst indigenous and Afro-descendant communities here in Guatemala. There's just, if you look at any health outcome by ethnicity, the differences are stark. Here are just some examples. If you look at COVID-19 vaccination coverage, is twice as high among non-indigenous. So like the vaccination coverage, for example, where I live in Guatemala City is about 97, 98%. It's higher than Atlanta, right? But then it drops to 20% when you leave. So that we're talking about huge disparities. And the same with poverty, malnutrition, any health outcome. And this really goes to power and privilege, and these power and privileges is what really drives a lot of our inequities. This is from Madhu Pai, a cartoon he did a few years ago in PLOS Medicine. But these powers can include racism, patriarchy, colonialism, and these are kind of the big things that if anyone's working in global health, I feel like we have to figure out how to tackle. And these are just some of the things we put together here at CDC on addressing these. We did a series on Indigenous health equity this past year. And here's a YouTube link if you want to learn a little bit more about that. We're going to continue that this year. And we're also working on how we can direct our funding at CDC when we give out funding, where grantees have to work with community-based organizations, have to address issues of health equity. So it's it's a small drop in the bucket of dealing with these huge imbalances, but there are concrete things that can be done, and then likewise can be done at the Center for Global Health in Colorado. So just to close, I wanted to kind of come back and kind of capture some of the bullets I gave throughout in terms of the proposed vision for the Center for Global Health, in terms of some of the strategic priorities. So I put them into 4 buckets. I think one would be focus on infrastructure. I understand the center is based in the School of Public Health, which is a great home for the center. Yet there's an opportunity for expanded connectivity with other schools, those on the medical campus, but also across the university, because again, to tackle these existential threats to the globe, we need collaboration, and so how can we set up the infrastructure where we can incentivize and make this possible? As a director, I would love to form/refresh an external and internal advisory board, because I think that is critical to make you accountable. I think it would be great to form a student advisory committee if that doesn't exist. And we did that at Emory, and some of the best ideas were from the students. The ideas don't come from the leaders. It comes from students and junior faculty. I think it's important to create a diversity, equity, inclusion, and belonging strategic plan specifically for all the reasons I've mentioned. Fundraising is going to be a big piece. To how does this center continue, beyond, and then having really strong metrics, and holding ourselves accountable to monitoring and evaluation. Just to give you an example, this is the kind of landscape analysis we did at Emory, with the institute being at the center of the hub, and then that's being essentially the hub to all the schools, so to all the deans of the schools, but then also different centers, affiliates, local, global. So I think kind of coming up with a similar visual in Colorado, if it doesn't already exist, I think would be essential in terms of communicating the value of what the center does across the university. These are the things I think deans and presidents like to see. And then the final three kind of domains would be around student programs. I know there's a lot already happening in Colorado. I think strengthening and integrating global health curricula across schools is an opportunity, because there's a lot in my understanding at the departmental level. But can we bridge these? Create a health sciences wide global health curriculum that brings together folks from different disciplines. I already mentioned the idea of establishing new training and research site, building from the Guatemala model, faculty programs, the faculty fellows program, seed grants. Another idea is to provide faculty development training in global health. I often get asked, how do you get promoted if you're working in global health, right? I'm a clinician, or a lecturer, and I've spent all this time in Africa doing this work, but I'm not getting the typical metrics. I don't have an R01. Like, am I ever going to get promoted? So can we create like a specific faculty development that from senior folks who've done this to give advice to junior faculty on how to succeed in global health? And then I think partnerships and visibility are critical. I think it'd be really great to do a landscape analysis of what other partner global health institutes are doing. This could be done in partnership with CUGH, for example, is something they should probably do, but I think Colorado could lead this, because it's changed a lot since global health institutes and centers first started. So where are partner organizations headed? Strengthening engagements with other international organizations and other universities within Colorado. And then I'd mentioned this forum series, not only just to raise the importance of some of these timely topics, but even more importantly, to raise the visibility of the Center for Global Health internally amongst faculty and staff in Colorado. And I think, if I were to come there, my first 90 days would be, really to listen, learn organizational culture, create new coalitions, champion equity lens, and personally, I like to practice inclusive leadership, and I think in global health, more importantly than any other field, that's critical, because you can't do it alone. So I know that I spoke very fast, but I think that's all I had for my comments, and I look forward to your questions. Thank you.
Well, thank you very much for this really impressive presentation, and allowing us to get to know you better and where your thinking is and experience has been. I'm going to open it up to the floor for questions for you from the audience. Since we're in a webinar format, I'm locked in a little side room with Parmi and administrator and colleagues that joined us in this conference room. I don't see any of you out there, but if you'd like to pose some questions, could you first go ahead and put your question in the Q&A part at the bottom of your screen, and then we can read it from here, from there, and Parmi can answer the questions. The floor is yours.
I'm sorry, I realized I went faster than I needed to. I thought I was ending at 3. I realized we started at 15
No,
after,
this is
so
fine.
I
So this is
apologize.
fine. This is fine. And also for those of you who, while we're waiting for some questions, so Dan, we have a question. So before, let me finish this one thought, Dan, and we'll get to it. Parmi, can you read that question on the Q&A? And while you're reading it, I'm going to just answer saying that this is also, the session is recorded. So let your colleagues know if they would like to view this particular seminar, that it will be uploaded to the recording and you can access it that way. And Parmi, do you want to answer Dan Olson's question?
Yeah, of course. Yeah, hi, Dan. Great question. His question's about addressing colonialism and global health and ideas on enacting bilateral exchanges and with partners. So critical. And I think we have to put our money where our mouth is. I think so, and it's not easy. So I guess our equivalent at Emory to Guatemala would be Ethiopia. That's where we've had the longest partnership with Addis Ababa University, and there's been primarily into school of medicine. Others have collaborated too, and it's been kind of your typical thing. We send like every year like 20 trainees, right? And go do rotations, do research, and there might be 1 or 2 that come to Atlanta every year. So when we created this globe, this new office in the school of medicine, we set out some kind of guiding principles, and then and then being able to see the budgets, essentially just allocated money where for every every person we're sending, we have to bring someone back too, and so that means less people get to go, right? So but that's, we felt that was really important to have that bilateral, and it's not, it hasn't been easy, because then the initial thought is like, how can foreign doctors practice or observe? There's like rules with the board, but we got through all those. It took some work, but now that is truly a bilateral exchange. So yeah, so I think it's doable. I think often, like centers, institutes of global health, they have to really address the business of global health, some of the logistics, the items, because and I think that I think is a critical role, because that's what's the added value then to doing, just working within your own school, right? Is like how can you get, how do you get grants? How do you do these bilateral exchanges? How do you conduct the business of global health in an ethically sound and also productive way that's not the same as doing an NIH funded study in Colorado. There are definitely differences. So I know that's kind of a long-winded answer, but I think it's those are some examples, and I think it's doable.
So thank you. Before you answer the next question, I think Parmi, do you want to close out your presentation? And I think then they can see the speaker. IT, is that right? They can then see the speaker, Dr. Suchdev. Anyway, while that's going on, would you like to take the next question?
Sure. So this is about FT. So I haven't gotten all the details in terms of if this is the roles, but presuming like most things, that's academia, right? We fill our pies how we can. We have to go hunt for what we're going to eat. So I would advocate for, regardless of who the director. I think the first question is what does what do people think is needed for this role, right, in terms of FT. And I can tell you, when I was brought in to be the associate director at Emory Global Health Institute, it was because the director got so tied into doing other things, doing research, their own things, that then couldn't be the director anymore, right? Like all these other things fell through. To be frank, right? Like the deans hadn't heard from the director because the director was busy. So I think that's like strategically an important question to sort out. Like what, like how much of a administrative role does this director need to do the work of the center in addition to their own things. I think I have many interests, as you've seen. That's part of one of the dangers, I guess, of being in academia. But I definitely want to continue to being a clinician. That's one of the things I miss, having joined CDC. And so I would love the opportunity to do that. I will say if all else fails, I still have my stethoscope, so someone will find a job for me. And I think that keeps I think that keeps you grounded, right? Too. So I think there's some value to that, and then of course some other independent research. But I would hope that research wouldn't be like Parmi's research or the director's research. Was this would be research that would be added value to the center and to the other faculty, based on their interests.
So we've got a few more questions coming up. And so thank you, anonymous attendee, for the wonderful compliment. But would you like to go ahead and take Sam's question?
Sure. Can you talk more about strategies for improving data quality collected from international sites? Wow, what a yeah, what an important question.
Tough one.
Yeah, I'm like dealing with that right now. We're actually in the middle of an outbreak here in Guatemala, and I'm like here in Guatemala, and we're planning a case control study, and we're going to go to the field next week. And this is exactly during my break, we're talking about data quality and how to do checks. So I think you have to data quality is critical, and you have to do it in a way that's done with the partner, not like as this, okay, we're this elite institution and we're saying your data is of poor quality and like we don't trust you, so we're gonna, you send all your data to Colorado, we'll like analyze it up nice and present it back to you. That's probably not the most ideal way. So it's work hand in hand. So so like double data entry. I mean, it depends on the data, right? If you're talking about data from questionnaires and or lab specimens. But I think that is critical. And I mean, one of my areas of interest is really, as I alluded to, is setting up laboratories and assessment tools. I think like any problem you want to fix, if you can't measure it, you're stuck. And often if the measurements are off, then you're making wrong decisions. And so it's kind of having better precision and accuracy on any measurement, I think is critical. And so I think those would be opportunities as well to grow on in terms of better assessments. Sorry, I don't know if it's hard to answer that without a specific example, but I think it's a push-pull question.
Yeah. Well, you take a look at Doug's question, we will certainly agree in this room here that data integrity, data access, data usage, and empowering locals to use data is really important. But, it needs a lot of guidance, and we can't just solve it alone. It has to be much of a global front, and could maybe provide some examples. So do you want to go ahead and take Doug's question?
Sure. And Doug's asking me a non-nutrition question. Thanks, Doug. I only know nutrition questions. Now, how do you think a Center for Global Health can address how corruption, crime, and war as they impact global health, as they can reverse 20 years of progress in a heartbeat? Oh, wow. Okay. Doug always asks hard questions. No, I think I mean, at a Center of Global Health, it's the place for global health for the university, right? So the center has to have a very broad view and be prepared and be able to appreciate that health is an outcome, but there are a lot of determinants to health, and I think all those things on your list are really, even in my role in Guatemala, those are where all the money and where all the focus is on, is addressing corruption, crime, and war, and then we're like the small health piece. So, but I would argue all of those are determinants of health, and health is the outcome that's the common denominator. So I think if we can kind of sell health like that as well to those who work in some of these other areas, then that gives us a common place to to have these discussions. I think war is probably the most imminent on anyone's mind. Just looking at what's happening, in Ukraine and Gaza, and politics aside. I mean, I think as health providers or professionals, whether we're in medicine, public health, or other health related fields, it's impossible to ignore that war is catastrophic for health. And besides saying never have war, how to mitigate that. And I think as kind of larger, like as a center, I think there's a voice to be had, and a way to advocate and put out voices to get at those, to not stay silent, I guess.
So thank you. So Amy, I apologize. I just read your note that the questions are not being seen by the audience. And so when you get to the next question, Parmi, could you just sort of phrase that question and then answer it? Thank you.
Sure. Okay, so the next question is from Karthik Shankar. What are your thoughts about addressing emerging issues in the global health context, such as a double burden of undernutrition and chronic disease, such as diabetes? Are the stakeholders for this issue different? Yeah, thanks for that. Yeah, having worked in the area of double burden of malnutrition, I can tell you it's what needs to happen. It's just a reality on the ground. And I think what you allude to in your question is that often the people working on these issues are not necessarily linked together, right? So you have the malnutrition, the undernutrition people, like, for example, who have their kind of bucket of interventions and grant funding and their mission, right? And then you have the chronic disease, overnutrition folks, and often there isn't an opportunity to bring them together. So I think you answered the question in your in your question too. So I think that is a way to do it, is to bring the two sides together, and to figure out ways to creatively address them simultaneously. And to my knowledge, there's we still haven't figured out how to deal with double burden. I mean, we have some ideas. We're still at the point of measuring it, because it is so complex, right? To do at least countrywide interventions, because usually the problems are in the same country, but are divided by socioeconomics, by geographies. But I think the same could be done with other global health problems that seem to be disparate, but need to be brought together at the same table. I feel like I'm doing that almost every day, as being the only kind of non-infectious disease person in the room, and reminding people that actually chronic diseases also make your infectious disease outcomes worse. So yeah, you can't think about one without the other.
Are there other questions for Parmi? If not, then I thank you, Parmi, for joining us. I know this is a long day for you because you have more sessions coming after this, but we're really thankful that you have time to present to us and let us get to know you better. We're really excited to have I especially am looking at the prospect of having a new director on board and taking University of Colorado, the School of Medicine, the entire health allied schools, and the School of Public Health to new heights with our director. So thank you again for sharing your time with us. For the audience, there will be a questionnaire following, and I'd like to ask everyone to make sure that you let us know what your viewpoints are. Okay. With that, then, thank you again, and we will close and give you a little time, as I said before, a little rest.
Thanks. It was great chatting with you guys, and thanks for all your great questions. Appreciate it.
Okay, thank you very much, everyone, for attending.